I'm Dr. Rosalie Stevens, a medical oncologist with an interest in treating patients with melanoma. In this third Immuno-Oncology podcast, I'm going to describe some of the side effects produced by the immune checkpoint inhibitor class of treatments. I'm going to describe general principles relating to these drugs, and then go into some of the detail relating to specific toxicities. The first point to make is that there are different drugs in this class which work on different ligands in the process of T-cell activation and regulation, and therefore the different drugs have subtly different side effect profiles. In general, however, the class of drugs is very well tolerated, and this is particularly true for the PD-1 inhibitors, such as pembrolizumab and nivolumab. In fact, when nivolumab was compared in a phase 3 clinical trial to the chemotherapy drug dacarbazine, nivolumab was better tolerated. Adverse events can be divided into infusion reactions, which are actually uncommon, and immune-related AEs. This slide shows the cornerstones of management of immune-related adverse events. And the first and perhaps most important of these is an understanding of the spectrum of side effects that can occur. We can't underestimate the importance of educating patients in the potential side effects. This treatment is given in an outpatient setting, and we therefore rely on patients and their families to report in with potential side effects. In Auckland, we give patients who are starting pembrolizumab or nivolumab a handy wallet card, which includes a checklist of red flag symptoms. Patients can use this as a reference guide at home, and they can also give the wallet card to other health professionals who may be treating them outside their usual healthcare environment. We try to anticipate some immune-related side effects by seeing the patients regularly in the clinic before their infusions, and by testing for certain lab parameters that may indicate a problem. For example, we regularly check liver, renal, thyroid, and adrenal function for those patients on PD-1 inhibitor treatment. If an immune-related adverse event does occur, then we usually interrupt treatment because dose reduction doesn't seem to be relevant to management of side effects. And if necessary, we institute immunosuppressive treatment, most typically corticosteroids, and we consider restarting the treatment if and when the side effect resolves satisfactorily. We can also consider referral to allied health specialists such as gastroenterologists, hepatologists, dermatologists, and rheumatologists. The more experience we have of the immune checkpoint inhibitor drugs, the more side effects we uncover. And we now know that inflammatory syndromes can occur in any organ of the body. However, there are some side effects that we deal with more frequently, and the most frequent side effects that we encounter are fatigue, skin problems, arthralgias, and thyroid dysfunction. There are some side effects, such as pneumonitis, that occur more commonly with the PD-1 inhibitors, and those that occur more commonly with the CTLA-4 inhibitors, such as ipilimumab, and this includes colitis. Combining a PD-1 inhibitor with a CTLA-4 inhibitor significantly increases the risk of side effects for the patient. Most immune-related adverse events occur early, within 12 weeks of starting treatment. However, there is some unpredictability as to their timing, and we have certainly seen patients developing very late side effects, or who have developed side effects even after we have stopped the treatment. It is important to note that PD-1 inhibitors are thought to have a prolonged pharmacodynamic effect, probably 3 months or longer, and this means that some side effects can become chronic, such as rash and arthralgias. It can take a long time for these side effects to settle even after we stop the treatment. It is also worth noting that immune-related side effects do not necessarily occur independently of each other and can occur in clusters in the same patient. Essentially, it is difficult to select which patients are at higher risk of developing an immune-related side effect on treatment. There are patients, however, who are probably at higher risk, and those patients are those that have had ipilimumab previously, and particularly have developed an immune-related side effect on ipilimumab, and those patients who have baseline comorbidities of inflammatory or autoimmune diseases. Putting those patients aside, our assessment of whether a patient will tolerate PD-1 inhibitor treatment is based on comorbidities and their functional status, and assessment of whether they will cope with the most severe form of immune-related side effect. This table outlines the general management principles of immune-related adverse events. If a patient is asymptomatic or there is a very mild side effect, we tend to continue treatment and keep the patient under close observation. Once a patient starts to have moderate symptoms from an immune-related side effect, we withhold the nivolumab or pembrolizumab, and we consider using oral prednisone. In patients with grade 3 or grade 4 side effects, we consider hospitalisation, the use of very high-dose corticosteroids, and involvement of other specialists such as gastroenterologists. I think it is important to specifically discuss the use of corticosteroids because we commonly use topical or oral corticosteroids to manage immune-related adverse events. And we're quite comfortable doing that because retrospective studies indicate that this doesn't compromise the patient's cancer outcome. When we use oral prednisone to manage an immune-related side effect, we do need to use moderate or high doses, and we need to taper the dose over a prolonged period, usually at least a month. It's important, therefore, that we look out for the complications and manage the complications of chronic steroid use, such as the risk of opportunistic infection, impaired glucose tolerance, and the risk of adrenal insufficiency if acute illness occurs. There are some patients who have chronic toxicities such as rash or arthralgias, and for those patients we sometimes consider using a low dose of maintenance prednisone. Immune-related skin toxicity is probably the most common problem we encounter on PD-1 inhibitor treatment. Skin toxicity includes rash, pruritus, and vitiligo. In melanoma patients, at least, vitiligo is associated with good response to treatment. Skin rash can be chronic, and we typically manage it with typical emollients, corticosteroids, and sometimes systemic steroids. We grade the severity of rash using the body surface area, and this picture shows a very typical pembrolizumab-induced rash. It is maculopapular, itchy, and tends to involve the torso. It is reasonably common also to manage thyroid dysfunction on PD-1 inhibitor treatment. PD-1 inhibitors can produce hyperthyroidism by mechanism of thyroiditis or hypothyroidism. Fortunately, most thyroid dysfunction is asymptomatic, and we usually attribute fatigue that patients experience on treatment directly to the drug itself rather than to hypothyroidism. There are some patients who require thyroxine replacement, and typically patients require it long-term, even after the drug has stopped. Immune-related pneumonitis is one of the feared complications of PD-1 inhibitor treatment. In the early trials of PD-1 inhibitors, there were rare patient deaths due to this complication. Sometimes it is picked up incidentally on a routine staging CT, as shown on this slide. If it becomes symptomatic, it is typically manifest by shortness of breath and dry cough. And those patients suspected to have pneumonitis should undergo a high-resolution CT to exclude the diagnosis. It can be difficult, however, to distinguish between an immune-related pneumonitis and another inflammatory picture, such as that caused by infection. Hepatitis and immune-related colitis are also potentially very serious side effects of PD-1 inhibitor treatment. Hepatitis is characterised by elevation of the transaminases and may be asymptomatic. Once a patient develops grade 2 hepatitis, we withhold the PD-1 inhibitor drug and consider whether we need to use steroids. Immune-related colitis presents similarly to inflammatory bowel disease with diarrhea and GI bleeding. And this slide shows pictures taken from colonoscopy with severe rectal inflammation. Again, these patients are typically hospitalised and treated with immunosuppressants. Hypophysitis, or inflammation of the anterior pituitary gland, is fortunately rare with PD-1 inhibitor treatment, but can be seen in approximately 15% of patients treated with ipilimumab, and should be considered if a patient presents with headache, neurological symptoms, or severe fatigue. As with thyroid dysfunction, the pituitary gland does not tend to recover even after treatment is stopped, and long-term hormone replacement is required. The point of this slide is not to remember all the weird and wonderful inflammatory syndromes that can be produced by PD-1 inhibitors, but to at least consider diagnosing them in patients who present with subtle or unusual findings. A good rule of thumb is to ask patients to report in if they have any new symptomatology, even if mild. It's also important to remember that those patients who develop the most severe immune-related adverse events may be those patients who best respond, and so ongoing treatment may actually not be required. A variety of management guidelines now exist for reference when treating patients with PD-1 inhibitors. ASCO and ESMO have produced very comprehensive guidelines. In conclusion, checkpoint inhibitors are generally very well tolerated, and severe immune-related adverse events are thankfully rare. Recognition, detection, and treatment interruption are the cornerstones of successful management. It's important to remember that inflammatory syndromes can be produced in any organ of the body and can present in subtle ways. The timing of immune-related adverse events is also unpredictable, so we must be vigilant for these side effects at all times during and after a patient's treatment. I hope that this podcast has provided you with an overview of immune-related adverse events produced by immune checkpoint inhibitors.